Good afternoon again, everyone. After each scientific speaker today, we will take 2 questions. Time permitting, we will do additional Q&A at the end. At this time, I would like to introduce our first speaker today, Dr. Diana Wilkie. Dr. Wilkie is a professor and director of the Center of Excellence in Palliative Care Research at the University of Florida College of Nursing. Her research has focused on pain and symptoms management using informatics, big data science, and patient-centered interventions to promote precision pain care for patients with cancer and sickle cell disease and to overcome barriers for pain control. The findings from her research program has appeared in 150 publications. Please welcome Professor Wilkie.
Thank you, Caroline. It is such an honor to be here today, to be able to share with you. I was given a very big mission, and it's following up with what Dr. Rada has just been speaking to. And I've entitled the talk today, Palliative Pain Care, Safety and Comfort for Everyone. Can everyone hear me? I have a soft voice, so if I'm getting low, will you please let me know so that I can get closer to the microphone? Well, it is such an honor to be here. This is my first visit to Howard, so after today, I'll be able to raise my hand very, very high. I'd like to share with you the issues of conflict of interest. I am a founder and chairman of eNursing LLC, and this company does receive some royalties from the American Psychological Association for online courses related to end-of-life care. But none of the other products that I'm talking about today are related to this company. Some of the products were, but I had to divest because of the issue of I was doing my research, and the research was more important to me than having the product in my company. I've been asked to talk a little bit about some new understandings about pain, and so Standing Under, we'll try to do a little bit of that, to describe some key palliative care concepts relevant to pain, and to describe some safe ways to achieve comfort. It's very clear that we have a very continuing problem, and this problem is multifaceted. It involves issues related to patients, providers, and systems of care. That would include also our major governmental systems also. We have many misconceptions and fears and concerns about using pain medications in terms of their side effects. And there's also often a reluctance to tell others about the pain that a person is experiencing. All of that gets in the way with the providers being able to do the job that they need to do related to assessing pain. And oftentimes in many of our educational programs, healthcare professionals are given inadequate information about doing pain assessments. And there is a lack of knowledge about analgesics and side effects. And one of the biggest barriers is the limited time to be able to deal with a very complex problem. And then in terms of our systems, it's so wonderful to see that Howard is putting pain treatment as a high priority, because many institutions list it as a lower priority. And there's clearly inadequate reimbursement. Many of those costs of those $600 million are related to lost work. But if we really think about how much money we're actually putting into the treatment, we're putting in way inadequate amount of care dollars in terms of helping with treatment. And then there's also very restrictive regulations, and there's issues related to people getting access to the best care throughout the entire nation, particularly in rural areas and in inner city areas where pharmacies may not even carry some of the medications that are needed to be able to provide care. Now, I'm telling you, this list of problems has been on our plate for more than 30 years. And as I'm nearing the last third of my career, I am so discouraged that we haven't made more progress. But I'm very enthusiastic because there is a beginning to have a greater emphasis on pain, and I think it's going to be really important because we can make a difference here and we can change, and that's what it's going to be really important for us to focus on. In terms of thinking about what's new about pain, I'd really like to bring us back to what is an old idea. However, as we apply it in a new way, it can really help us a great deal. And that's to look at pain not as a simple problem, but it is clearly a multidimensional problem. And because I have such a poor memory, I wanted to come up with an acronym to be able to always remember what those dimensions were. So I call them the ABCs of pain. And the first dimension would be the affective dimension, so the emotions related to that experience. And we've seen a lot in terms of, if we look at the poem from Nikki, it's quite clear that there are some major emotional responses to unrelieved pain. There are also a number of behavioral dimension issues related to how other healthcare professionals and other in the environments interpret a person who's experiencing pain in the way that they're behaving. Oftentimes, if they're asking for pain medications on the clock, that is a drug-seeking type of behavior. I would counter it's a pain relief-seeking behavior, and it's really important for us to really reframe some of our understandings about the behavioral dimensions of pain. And then there's the cognitive dimension of pain. So it's all the thoughts and beliefs and attitudes about pain that can interfere with us getting good pain relief. And then finally, there's the physiological sensory dimension of pain. And there's been a great deal of work in this particular area so that we understand more about pain mechanisms. We understand more about the pharmacokinetic of different drugs. We understand more about polymorphisms in our genetic makeup that make some individuals not able to effectively metabolize drugs so that they can get good pain relief. So it's not that they're drug seeking, they're seeking a drug that will work for them because their body metabolism doesn't allow some drugs to work well for them. So we're learning a lot about the physiological sensory dimension. And I'd like to focus a bit on the sensory dimension because I think that if we're understanding more about the sensory dimension, which is how it feels to the person who's experiencing the pain, it can give us lots of insights into improving pain management, particularly thinking about the important need for good pain control. The other thing that I think is quite important is to think about the different types of pain. We've been thinking a lot about acute pain that comes on right away. It's caused by some disease or illness, some trauma or injury. There could also be chronic pain that is there because of a number of different conditions that we don't necessarily know that there's a cure for that particular condition. Low back pain would be an example. And then there are also pain related to malignant processes. In other words, an ongoing destruction within the body, such as cancer, or even arthritis could be considered a malignant process. So it's not malignant in the way that we think about cancer, but it can be an ongoing process that can lead to severe pain. Those conceptualizations of pain are great, but they're limited because we also know from our modern research that there's another way for us to conceptualize the pain, and that is whether it's nociceptive pain or neuropathic pain. The nociceptive pain would be the pain that comes because the body is responding to the injury or the trauma, and it's activating nerves in our body. And it would be activating receptors related to pressure or temperature or chemical stimuli that can be causing the body to produce a pain response. And that's a very important aspect because all of those aspects could lead us to some drug therapies that could actually interfere with those processes. But another type of pain is the neuropathic pain, which results from damage to not skin, muscle, bone, and visceral tissue like happens with nociceptive pain. It's the pain that comes about because the nervous system has damaged itself. And it could be either in the peripheral nervous system, or it can be in the central nervous system, or, as one of our speakers is going to talk about today, it could be the way that the nervous system talks to itself within itself, both between the peripheral nervous system and the central nervous system. And we've known for many, many years of a variety of different pain conditions that are talked about in terms of neuropathic pain, like trigeminal neuralgia, or if there's some type of pulling out of the shoulder and there'll be a brachial plexus avulsion producing a type of neuropathic pain. We also can see that cancer, for example, lung cancer in the top of the lung, can compress the brachial plexus, which is a nerve group in the shoulder, and can cause pain down the entire arm. And that pain is a very different kind of pain than the nociceptive type of pain. And it's been very interesting because some of our work is coming from understanding pain mechanisms and working mostly with cancer. When I came to sickle cell, I was very surprised when patients with sickle cell started to share with us descriptors that would indicate that they might be having neuropathic pain. And this happened about 7 or 8 years ago, and our reports are some of the first reports to really focus on that even sickle cell pain could have a neuropathic component. And certainly it's stimulated a lot of research in this particular area. But a really important aspect related to pain is for us to recognize that there are pathophysiologic consequences of pain. It can kill. So pain isn't just an annoyance. Pain is dangerous. And we know from a variety of different studies that pain can affect the immune system. It decreases the immune function, it decreases the number and the activity of the natural killer cells. And in animal models, it has led to earlier death. So pain isn't just an annoyance that we need to, pat somebody on the back and say, oh, well, it's going to get better. Pain is dangerous and it affects our immune system. It can also affect our pulmonary system, because when people hurt, when they need to breathe, if they hurt, they're not going to take deep breaths. And that type of splinting will decrease the vital capacity of the lung. It will decrease the functional residual capacity in the lung. And it decreases the air sacs from fully ventilating so that people aren't getting the oxygen that they need to get. That results in atelectasis, pneumonia, and hypoxemia. And so sometimes when we're thinking about the effects of the opioids, and we think that that's what's causing our hypoxemia, we need to think a little bit deeper and say, might we be seeing some of these effects of unrelieved pain on the pulmonary system? Also, the effects of unrelieved pain on the cardiovascular system, with overactivity of our sympathetic nervous system, which increases the heart rate, which actually then decreases the oxygen to the heart, increases the peripheral resistance and the blood pressure and the cardiac output, increases the oxygen use, also results in hypoxemia and can result in ischemia of the heart in the periphery. And so recognizing that pain itself can be leading to some of these cardiovascular problems that we often blame on the pain medications that are being used. Also in the gastrointestinal system, again, it's that sympathetic overactivity where it increases the GI secretions and it increases the sphincter tone of the smooth muscles in the GI system, which then ultimately decreases the motility of the intestines. And so if you're going to decrease that motility, it can result in gastric stasis. So food won't empty out of the stomach the way that it needs to empty out, so people feel full. and they can't take more, and if they're not taking their nutrition, that causes more problems. And it can also lead to a paralytic ileus, which means that the bowel closes down. And we often blame this on the opioids, and we need to really rethink this and say maybe it's unrelieved pain that is causing this problem. And when I gave a talk to some surgeons in Oregon about this particular, they go, well, we've been having a lot of problems with paralytic ileuses after surgery. You mean if we give more pain medicines, maybe we won't have so much? And why do you want to try it? And they did, and it solved their problem. So sometimes our dogma is true dogma, and we really need to rethink what we know about the entire pain system. The other thing is that it can affect the musculoskeletal system, which increases in muscle spasm, that impairs muscle metabolism, which can then lead to muscle atrophy. And in some populations, they may not be able to recover those muscle cells, and it could lead to functional decline that is very, very important. So really thinking about how we are able to adequately control pain and help to protect the musculoskeletal system. And then, of course, the effects on the nervous system, both peripheral and central, with the plasticity, and we're going to have another talk, so I'm not going to go into details about that now, but the nervous system changes, and those changes are not for the best. And then, of course, there are the psychological consequences, which many of us have always focused on, these psychological consequences. And recognizing that the fear and the depression, the anxiety, the helplessness, hopelessness, that severe distress, but all of that can lead to a decreased will to live. And so many people that I've worked with who've had unrelieved pain, their first thought is, well, my way out is suicide. Or they're asking for assistance in dying, so euthanasia. So we really need to think differently about these consequences of pain, because as we've been flashing up here on the board earlier today that we want to identify people at risk for suicide, well, people without good pain control could be at risk, and we need to consider that. So all of this evidence would indicate that we need to focus on a new model. And this new model clearly, we need to focus on curing the cause of the pain. We want to treat the injuries. We want to treat the diseases. We want to treat the illnesses. But we also need to be thinking about preventing pain. And definitely, if we can't prevent it, we want to palliate it. And palliate means to relieve. You may not be able to cure it, but you can be relieving it. And palliative care is not just for people who are dying. Palliative care is for anyone who's having unrelieved symptoms if they have a serious illness. And most of the illnesses associated with persistent unrelieved pain would qualify for palliative care. So what I'd like to do is to share with you a poem related to palliative care, and I was so pleased to see that I was following up. I planned this before I saw Nikki's poem, but I'd like for you to listen to this, and because it relates to some of the palliative care concepts. My heart is full of good intentions. I want to help using all I know. I know a lot you don't know about: diagnosis, treatment, risks, benefits, statistics. How can I assure you know enough so you can make the right choices? I protect my heart so I am safe from making choices, from sharing your life. The poem continues. My heart is full of life. I know a lot you don't know about: love, hope, grief, fear, illness, mortality. How can I help you know enough about who I am so you can help me make the right choices, so that we can share our knowledge and our lives? This is a poem by Stu Farber called Two Worlds, and we lost Stu in February. But he wrote this poem about his care during his battle with acute myelogenous leukemia. And you might recognize that the first poem was about the healthcare provider, and the second part of the poem was about him as a person. And what's really important is that we need to really represent and understand that patient perspective. Stu went on to say, every clinician Lou and I have interacted with is more afraid of death than we are. They focus on solving the problems of our illness with little awareness of how we want to live our lives. It is a paradox. The clinician is focusing on treating the illness that threatens life, but the life of the person who is ill is invisible. And I think that these words are so important because they represent the palliative care perspective. We really want to focus on the person who has the illness and help them to live the life that they would like to live. And so palliative care focuses on eliminating pain and suffering and optimizing quality of life for patients with serious illness as well as with their families. So it's not just patient-centered, it's also focused on the family. So it's patient-centered, but family-focused also. And what's so important is that to provide this patient-centered care, we need to focus on learning what's important to the patient, to balance treatment with the wishes, values, and spirituality of the people and their families, especially when it comes to pain care. It requires us to be present, to listen to people and expect pain control based upon patient goals, rather than only expecting enough pain relief for the patient to function. Because in most of our literature, it would indicate, and I observe this also in clinical care, that healthcare professionals are pretty happy when the pain gets to about a 3 or a 4, but patients are wanting it down closer to the 0 level. And so, yes, people may be able to function at a 3 or 4, but they don't have the life that they want to live. And that's what's so important, is for us to, but that also varies from person to person. And if we listen to the individual person, we can be guided by what the person wants rather than our assumptions about what they should be experiencing, what they should have. And I believe that the way that we can apply these palliative care concepts so that we can safely achieve comfort, the first step is to measure the pain. And notice I'm saying measure the pain, not assess the pain. Because assess means that you're just estimating it. We have tools where we can actually apply a metric. Can we really know exactly what's happening with all of the transactions that are happening at the nervous system? No. But pain is a subjective experience, just like eyesight is a subjective experience. And we have accepted the Snellen eye chart as a measure that we will use to be able to do corrective treatments, to be able to help people to have a restoration of their visual acuity. But for some reason, when it comes to pain, we resist this idea that we can measure the pain. But if we measure the pain as a multidimensional phenomenon, it really helps us to guide the therapy, and that guiding is so much more important than just looking at the intensity. For example, if we had not looked at the quality of pain that the patients were using to describe their pain, we wouldn't have had the insights that maybe sickle cell pain, some patients with adults with sickle cell might actually be having neuropathic pain. Then another thing that's really great, because we have new technologies today, because the patients can actually report. So it becomes a patient-reported outcome using tablet technologies. And if we are to do this, and this is a program that we developed, and if this is the one that is no longer part of my company, it's owned by Nursing Consult LLC, and I have no interest in that company or stock or voting or anything. I have no power at all. But it allows us, and we're actually conducting a study now in hospice, and we've done studies with sickle cell, where both patients and caregivers can participate. We do pain assessments and medication use. We also assess their symptoms. The patients are able to draw right on the tablet where their pain is located. And then they're able to use buttons to describe the intensity of their pain. They're able to pick descriptors to describe how their pain feels. And these words are sensory words. These words are also emotional words. And many of these words are also neuropathic descriptors. They also tell us how their pain changes with time. And this was actually the part that was hardest for people with sickle cell disease, because they've had pain over their entire lifetime, and really understanding how the pattern is changing. We need to be more deliberate about getting that information. But we also asked them to write their own words if we didn't have enough. But this tool is building on the McGill Pain Questionnaire, which was developed by Ron Melzak and published in 1975. But he started collecting the words from patients in pain in 1953. And those words came from patients. And then it took him from 53 until 75 to organize them into a metric, into a measure that we could be using today. Unfortunately, we're not using it in clinical practice, but my goal is to change that, and many other people's goals too. Patients also want to tell you which words go with which pain site. And Ron Melzak didn't capture that information on his paper and pencil tool, but with tablet technology we can do so. We also want to know what the goal for treatment is. What number would they like it to be, their optimal goal, as well as their tolerable goal, what would be acceptable to them. This way we can then personalize the care at the individual level, and not just say, well, everybody has to have a pain less than a 5. It really depends upon the individual patient. We also want to know how much time during the past 24 hours was the pain less than they're able to live with score. And then, is it worse than or not as bad or same as they expected? Are they satisfied with their pain? And we're finding that satisfaction is actually related to their pain intensity, whereas much of the other literature on satisfaction related to pain management shows no relationship. I think we've been measuring the items incorrectly in the past, and there's a new paper in press that will talk a little bit about that in people with sickle cell disease. So the way to be able to use those data, and I just gave you just a few ideas about how to measure, and clearly we wouldn't want patients to do that all the time, but once you get an understanding of how the pain is feeling, you can then cut back and only measure certain dimensions as appropriate. And I have to tell you, when I first started using this research and this research tool, the McGill Pain Questionnaire, in my research, as a clinician, I looked at it and I said, it'll never work. It's too long, it's too laborious, people don't know those words, and it just isn't going to work. Well, the 4th patient who participated in my study, after she completed it, she goes, now I can tell my doctor what it feels like. I had it wrong. Many people don't have the language to talk about the experience that they're having. They feel it, and they think we should be able to feel it too. But the only way we can begin to understand it is through the way that they're able to describe it to us. So if we're able to look at the location, the intensity, the quality, the pattern of the pain, and the patient's and family's goals, palliative care can eliminate pain by really applying pain science to patient and family goals, linking that measurement data to pain mechanisms, because we can see those. And clearly in sickle cell, we've been doing quantitative sensory testing, and indeed in a small sample that we've recently published, the neuropathic pain is very likely to be quite prevalent. We're now conducting another study with a much larger sample, just funded by the Heart, Lung, and Blood Institute, and we'll see whether or not the small sample findings hold up in a larger sample. But also, we are recognizing that if you're able to take that information, and for example, people who reported at least 4 neuropathic descriptors of pain were invited to participate in a study of a mechanism-driven therapy, and it was a CAMK2 inhibitor, which is a different mechanism related to pain, and that was published about a year and a half ago. And indeed, the individuals who had some sense that they might have neuropathic pain got tremendous pain relief when the dose of the study drug escalated to about 2 to 5 to 7.5 milligrams, and 10 milligrams was too much because it caused side effects. And so we need to be thinking about linking these mechanisms to the way that people are describing their pain so that we can be very thoughtful about linking the information together. Applying the pharmacokinetic and the dynamics of the drugs, using multimodality therapy, as one of our speakers is going to focus on today. And then what we really have to do is we have to titrate and change the therapy based upon the patient's responses until those comfort goals are achieved. Too often we have a set plan, and when that set plan doesn't work, we're out of our limits. We're not quite sure where to go yet. So what we have to do is we have to really walk by the patient and with the patient, continuing to listen and to use all of our knowledge about pain mechanisms and pain measurement, drug therapies, non-drug therapies, to be able to find the right cocktail that works for each and every patient. And maybe I'm Pollyanna, but I do believe that is possible. But it also comes from helping the patient understand that oftentimes if they're so anxious about not getting good pain control, that can actually contribute to the pain. So for example, one of the things we teach our patients is that our concern, our fear about pain isn't just in the brain. We now know, we've known for more than 20 years, that the sympathetic nervous system, if it's revved up and releasing norepinephrine, it can cause the neuron to fire with no other stimulus whatsoever. When patients recognize that their own emotions are dramatically or could dramatically be contributing to the pain, it helps to put together a therapy plan that uses the skills and talents of all of the individuals. And that way we're able to titrate and change the therapies until we're able to come to a state where we're able to meet the comfort goals for each and every patient. So in summary, I think that unrelieved pain is dangerous and inconsistent with effective palliative care. Different treatments are needed for nociceptive and neuropathic types of pain. Multidimensional pain measures provide important insights for the selection and timing of our therapies, and we've been timing and selecting drugs based only on intensity, and I think that's where we've been going wrong. It's good, but it's insufficient. And then our patient responses can guide the therapy changes until pain is adequately relieved from the patient's perspective. And we recognize that multimodal therapies are often required for the complex pain syndromes that many patients have. Those that don't have complex pain, their pain is relieved pretty quickly, and they're not part of that 116 million individuals who are having unrelieved pain. I'd like to recognize investigators I've worked with, students that I've worked with in a variety of different colleges, and then also my research team. And I don't know if we have time for one question or two? Two questions.